Welcome to the Platelet Couch. My name is Fazal Tatar. I'm a senior medical science liaison with SOBI North America. Today, joining us here is Dr. Jim Bussel, world-renowned expert in immune thrombocytopenia from New York. Thank you so much for joining us.
My pleasure. Thank you.
So, Dr. Bussel, to start off, how did this patient present?
I think this patient's presentation was pretty typical, had some bruises, petechiae, that kind of stuff. They presented to somebody else and then came to me as a second opinion, so I wasn't actually there at presentation.
So at what point did you get involved in their care then?
After they'd had ITP for give or take a year, I think it was what I think of as the usual, I can't stand taking more steroids thing.
Okay. So how was this patient managed with their ITP then?
They were getting prednisone and the dose was going up and down a little, and they would respond. He would respond when the dose was increased. And then when the dose was decreased, his count would fall, and he was getting very frustrated. And the other physician at the time, this was give or take 10 years ago, didn't really know what to do. And so he decided to find somebody else to come to.
And so when the patient presented to you, what therapeutic options did you discuss with the patient, and what was the patient started on?
Well, way back in the beginning, I would discuss too many options, so that got the patients generally very confused. So this time I stuck pretty much to rituximab or a TPO agent and just briefly mentioned immunosuppressives. He opted for rituximab because, there was the hope of having a cure or at least having a long-term response, say a year with no treatment needed and not a lot of counts, etc. So that's what we opted for. And I typically use dexamethasone with rituximab. So that's what we did. He developed what we think was serum sickness, though it wasn't completely clear afterwards, with the fourth infusion. So he did well for a while after that. He did well for at least 6 months after, but we couldn't go back to that, thinking that maybe we would give it, I'm making this up, once a year to try to keep things going.
Okay. And so then after rituximab, what was the next option for the patient?
Well, of course, we discussed splenectomy, but he really didn't want to do that. And he wasn't in the most stable shape. His wife had died a bit before, and he was a bit anxious and still trying to figure his life out. And he really didn't want to do that. So we talked about TPO agents, and he opted for romoplastin as opposed to eltrombopag.
And so how did the patient's experience with romoplastin go? And then what came after that?
Well, for a while, romoplastin was fine. He was happy to have good counts. Things were rolling along and he didn't have to worry about bleeding, and it seemed like his energy and general sense of well-being was a little better, but he started to have more and more aches and pains. So that seemed to be less and less comfortable. So after avatrombopag was approved, we had another discussion about maybe staying with the TPO agent, but going to a different one since he was doing well with it.
Okay. So avatrombopag being Doptelet.
Yes.
Okay. And so once the patient started on Doptelet, what dose did they start on, and what was their platelet count?
Well, they started on 20 milligrams a day, standard dose, and he did quite well with that, and his count most of the time was well over 100,000, and he was happier with that. And given the previous uncertainties, he was happy to stay on that.
Okay. I know we have a graph here. Could you tell us how the patient responded to Doptelet?
Well, the patient started taking Doptelet, even though his count was not like less than 30 or 20, because he was on romoplastin and we were transitioning him over to Doptelet. So we stopped the romoplastin and started the Doptelet at the same time. And you can see from the graph, the way the count went up, that he did very well with it. There could have been concern about his count being a little higher than where we would usually shoot for, but he was a bit nervous and anxious. We discussed, I think, that his wife was no longer with him, and that made him a little bit more uneasy. So he felt very good and was very happy with the counts, and so I was willing to go with that. He didn't have any history of thrombosis or have thrombosis in his family, so I had no extra special concerns that he might develop a clot.
And since the patient started Doptelet, how long has the patient been on it?
I think it's about 4 years now, and he continues to just do fine.
Okay. So could you tell us a little bit more about why Doptelet was chosen as their therapeutic option?
Well, when we chose it for him, he was not really eligible for rituximab again because of the serum sickness, and he really didn't want to have splenectomy, and I was not eager to offer it to him. So since he had done very well with romoplastin as far as platelet response and general quality of life, except for the aches and pains, which had gotten very problematic, it seemed appropriate to try to use a different TPO agent. So we chose Doptelet after discussing the pros and cons of Doptelet versus eltrombopag. For eltrombopag, the primary pro is the long amount of experience with it and the long-term safety data. The cons are the obvious ones, which are it can dominate diet and eating for the day and can be very difficult at times, and also that you need to monitor liver tests pretty regularly. So I think with Doptelet, it was much easier. You can take it with food, but 5 p.m., 8 p.m., any of that's fine.
Okay. So since the patient started on Doptelet and then you're their healthcare provider, how would you describe their experience with it?
I think their experience with it was all good. They just had to take it 1 tablet a day whenever they were eating. So, if it was 8 p.m., 5 p.m., whatever, it didn't really matter very much. They were happy. They didn't have to come for injections. They didn't have to completely regulate what the diet was, because I've had a lot of patients on eltrombopag, and while you can definitely work with them and come up with things that work for patients, it's not easy.
Yeah. And then what side effects have you seen in patients who are treated with Doptelet, and how do you manage those?
Well, I didn't really see any side effects in this particular patient. The very first patient I treated as part of the phase 2 clinical trial developed a really bad headache in connection with her count overshooting, because I think she was on the higher end of the 5 doses you could be on in the phase 2 trial.
So for this case series regarding this patient with ITP, what are the key takeaways for us?
When our center was doing the phase 2 study, which was published in 2014, we entered 26 of the 64 patients, even though it was a multi-center study, because we and the patients really just loved it. It seemed great. It would seem to be a very good agent. Brought up the platelet count well, and didn't seem to have a lot of the things that made eltrombopag a little hard to work with, diet and testing for liver tests, that kind of stuff. And it was 1 tablet a day, so you didn't have to get a shot, all that kind of stuff. So the patients loved it. We loved it.
Well, Dr. Bussel, thank you so much for joining us today on the Platelet Couch. For everybody at home, thank you so much for joining us today. Please do watch the other videos in the series as well.
Doptelet, avatrombopag, is indicated for the treatment of thrombocytopenia in adult patients with chronic liver disease who are scheduled to undergo a procedure, and in adult patients with chronic immune thrombocytopenia who have had an insufficient response to a previous treatment. Before taking Doptelet, tell your healthcare provider about all your medical conditions, including if you ever had a blood clot, are pregnant, or plan to become pregnant. Doptelet may harm your unborn baby. Tell your healthcare provider if you become pregnant or think you may be pregnant during the treatment with Doptelet. Also tell your doctor if you are breastfeeding or plan to breastfeed. It is not known if Doptelet passes onto your breast milk. Do not breastfeed during treatment with Doptelet and for at least 2 weeks after the last dose. Talk to your healthcare provider about the best way to feed your baby during this time. Tell your healthcare provider about all the medicines that you take, including prescription and over-the-counter medications, vitamins, herbal supplements. Doptelet may affect the way other medications work, and other medications may also affect the way Doptelet works. TPO receptor agonists have been associated with thromboembolic complications in patients with chronic ITP. Thromboembolic events, arterial and venous, have been reported in patients with chronic ITP treated with TPO receptor agonists. Consider the potential increase in thrombotic risk when administering Doptelet to patients with known risk factors for thromboembolism, including genetic prothrombotic conditions and acquired risk factors. Monitor platelet counts for signs and symptoms of thromboembolic events, and institute treatment promptly. Serious adverse reactions that have occurred more frequently in patients treated with Doptelet compared to placebo was headache. The most common adverse reaction, occurring in 10% or more of patients with chronic ITP, were headache, fatigue, contusion, epistaxis, upper respiratory tract infection, arthralgia, gingival bleeding, petechiae, and nasopharyngitis.